Like he said, my name is Joseph Enegela. I do not have any quotes to give about Madiba, but I'm sure he's dear to us all. Probably the most important man of this century. May he so rest in peace. I'll present to you findings from a review that we carried out. It was a program review under the AIDS Relief Program. And all the other speakers have told us about the scourge of TB and HIV, and I need not pay more lip service to that, but we need to know that 7 of the 22 high-burden countries of tuberculosis are in Africa. And therefore, we need to pay a lot of attention to TB. TB in 2012 was responsible for the death of 1.3 million people. About 320,000 of those were in HIV-positive patients. The bulk of them in sub-Saharan Africa. Sub-Saharan Africa in particular here because we have very fragile health systems. And the continued prevalence and the incidence of tuberculosis, especially amongst HIV patients, will increase the burden on our health systems. Its presence also has had an effect on how and when we start therapy amongst HIV-positive patients. It has gradually become an absolute indication now for ART. It also determines what antiretroviral drugs we give patients because of the drug interactions between rifampicin and other ARVs. So if you have patients that have tuberculosis and HIV, your spectrum of ARVs are narrowed. You just have to use efavirenz. So our objective, as part of a broad program review, we sought to evaluate the outcome of our patients who had tuberculosis at the initiation of therapy and see what became of them within the program. This is important because it is very easy for us to get lost in the myriad of activities that we carry out with our patients and not try to see what their situation was at the beginning of therapy. A lot of the patients that initiate antiretroviral therapy probably are not used to taking medicines. So you're starting them on antiretroviral therapy, they're taking medicines that they're not used to, adherence becomes an issue, and then you've included TB therapy as well. So we wanted to find out what happened to those cohort of patients amongst our group. So this was a cross-sectional retrospective review of adult antiretroviral therapy patients, at least 16 years and above, who had been on ART for 9 months. We used 9 months because that was enough time for anybody who had started antiretroviral therapy to be successful or to do well or have the viral load suppressed. This was done across 12 comprehensive treatment facilities in Nigeria, across at least 4 regions in Nigeria. So what did we do? We reviewed the patient charts for demographics, age, sex, duration on therapy, antiretroviral therapy type, and the presence or absence of tuberculosis at the beginning of therapy. Our definition of the presence of TB at initiation of antiretroviral therapy was a TB diagnosis 3 months prior to initiation or 1 month of initiation. Our thoughts were anybody who had TB within a month of initiation probably has had that TB. Maybe it was a delay in diagnosis that made them not have that. And then we also reviewed for documented evidences of attrition from care. And attrition from care we defined as loss to follow-up with documentation that in the 90 days since the person came to the facility, attempts have been made to seek this person out in the community. Deaths from all causes, transferred out. I know that will bring some contention because transfer out from facilities are not considered regularly as attrition. But we use this for 2 reasons. One, a lot of our health systems are not so developed and therefore we don't get slips, return slips, so you do not know if that patient got to that facility. And some observational studies have shown that some of the patients who are transferred never do get to where they are going to because some of the costs for transfer may even be higher care, more specialized care, which may be more expensive. And then our last definition was stopped, and this was physician stopped for any reason that in the course of management. So, using those definitions, we divided our patients into 2 groups, the TB group and the non-TB group. And we evaluated these 2 groups for probability of attrition from care. We used Theta version 12 in doing this. Demographics are The sample size was 1,262 patients. This was a representative sample of patients in those facilities. And our male-female ratio, our female population in this group of patients was 65.3%. This wasn't too different from a lot of other HIV cohorts that we have in sub-Saharan Africa. The average age of this group of patients was 37 years. So, about 10% of our 1,262 patients had TB by our definition at the initiation of therapy. And of these 123 patients who had tuberculosis, 8 of them had been lost from care. That represented a 6.5% attrition rate within those patients. While of the no TB group, they had an attrition rate of about 2.3%. On closer examination of the cause of attrition for the no TB group, we realized there was an almost even distribution between lost to follow-up, death, and transferred out. However, when we looked at our TB group, there seemed to be a high percentage of patients who were lost due to transfers. Let me put this in context. In the TB program in Nigeria, we have what we call the microscopic centers, which are the diagnostic centers, usually secondary facilities. And then we have the DOT centers, which are the treatment sites. So usually patients will have their diagnosis made at the microscopic centers and then have their treatment referred to the DOT centers, which invariably are usually close to their homes, so they can carry out their daily observed therapy. Now, at the time of this review, we had not started decentralizing ART services. So this was important. On follow-up, we found out there was really no difference in the two groups on the median months on follow-up. The TB group were followed up for a median period of 26 months, while the no TB group 27 months, with a range of between 10 to 67 months between both of them. We now sought to compare the two groups to see if we could find a difference in the risk of attrition from care. And we found out that the TB group had an almost 3 times relative risk of attrition. So, putting my context in mind, our discussion, we transfer patients regularly for TB care. In as much as this study, due to its retrospective nature, didn't document if those transfers were just due to the TB care. Remember, this is an ART program we're reviewing. The question that we asked was, could these transfers that we found out, that we observed in our patients, have been due to the transfer of their TB care? Could it have impacted on the ART care? That we couldn't find out, we couldn't ascertain because of the retrospective nature of the study. However, the observations are clear. Patients who had tuberculosis at initiation of therapy were more likely to be lost from care, and transfers seem to be significant in co-infected patients. So therefore, we say, we may require further studies, one with better records, maybe prospective study, to see if retaining patients' TB care at the ART centers would be more beneficial than having them transfer for the TB care to their homes. That is if the hypothesis is that the TB transfer was what was responsible for our rates of loss to follow-up. Loss to care. I would like to acknowledge the following persons who worked with me on this, and the AIDS Relief Nigeria CQI team. AIDS Relief Nigeria is actually a rested program now. It was rested in 2011. And I acknowledge these persons. Center for Clinical Care, my immediate past employer where I was working. Maryland Global Initiative, University of Maryland. Gilead, which provided travel grants for my being here. And you will see my badge. That was the part I didn't add in the introduction. I'm an emerging voice for global health 2013. It's an initiative of ITM, Institute of Tropical Medicine, Belgium, and University of Western Cape School of Public Health. I would like to thank them for this opportunity to be here. Thank you very much.